Right. Hi friends. In this session, I'll be discussing about CBD stones. Okay, common bile duct stones, and I'll be discussing about the important questions related to the NEET PG. Sorry, NEET. What super specialty? NEET PG super specialty. Yeah? So the point which we need to understand here is the primary common bile duct stone arises de novo in CBD, and it's also written that secondary common bile duct stone passes from gallbladder into the CBD, and the primary gallbladder stone, it's written that brown pigmented stones, okay, and they precipitate bile pigments and plus cholesterol, and pigments are, it's written that bilirubin yellow and biliverdin green. So let us understand what is it trying to tell us here. In this session, I have told you we started speaking about the common bile duct stones. The common bile duct stones, there are of two types. The one you have known as primary common bile duct and secondary common bile duct stones. What is primary common bile duct? That means if you look into the diagram here, this is the diagram which tells this is a gallbladder, this is a cystic duct, this is a common hepatic duct, this is left hepatic duct, right hepatic duct, right? This is an and you have got a common bile duct. Okay, this is the common bile duct. Now the topic totally depends upon how the stone is formed here, how the stone has come. So there can be a mechanism where you don't have a clear-cut pathophysiology. You have something known as primary gallbladder stones, which arises from de novo in the CBD. There's no clear-cut pathophysiology, pathogenesis. Next, you have something known as secondary common bile duct stone. And what do you mean by secondary common bile duct stone? It is a stone passes from the gallbladder into the common bile duct. Stone passes from the gallbladder into the common bile duct. That is how the primary common bile duct and the secondary common bile duct. And the primary common bile duct stones, it's written that there is something known as a brown pigmented stone. What do you mean by brown pigmented stone? It means that you have a pigments, right? What are the pigments here? That is a bilirubin and you have biliverdin. Bilirubin is yellow in color. Biliverdin, very good. Biliverdin is green in color. Now this brown pigmented stone, now how it is because of a precipitation of bile pigments, that is bilirubin, right? Bilirubin precipitates and plus a cholesterol. That is how the primary gallbladder stones are formed. Okay, so mainly it is a primary brown pigmented stones because of precipitated bilirubin, what is brown or biliary pigments, right? Pigments, and you have cholesterol. Now, brown pigmented stones are associated with bacterial infection where the free bilirubin is formed by hydrolyzing enzymes released by bacteria and then precipitate. And it's also written that the brown pigment stones are common in Asian populations and secondary stones are most common in US. Now what is it trying to tell us? You have something known as a conjugated bilirubin. The conjugated bilirubin converts into unconjugated bilirubin by the presence of what? By the presence of an hydrolyzing enzyme. And what is a hydrolyzing enzyme here? That is beta glucuronidase. And this beta glucuronidase converts the conjugated bilirubin to unconjugated bilirubin, right? And this unconjugated bilirubin, they precipitate, right? And they helps in the formation of stones. Now these brown pigment stones are common in Asian population. That's all you should understand, the basic points of the first or the primary CBD. And you have got something known as secondary CBD stones, The secondary CBD stones are most common in US. Remember, the most common in United States. Now we have an important question here, which tells us you have something known as retained stones and you have got something known as recurrent stones. What is retained stones, guys? Retained stones are the stones where they are within 2 years of cholecystectomy. That means a person who underwent cholecystectomy occurs in 1 to 3% patients. It is seen in 1 to 3% patients where there is the stone forms after or within the 2 years of cholecystectomy. That is known as retained stones. And these retained stones are mostly, remember, the retained stones are mostly of mixed and cholesterol. They are mixed and cholesterol. And they are the stones in CBD. They are stones in CBD. And you have got something known as recurrent stones. And these recurrent stones are made up of brown pigmented stones. That means these recurrent stones. What do you mean by recurrent stones? The stones in the CBD after 2 years of cholecystectomy. They can give you a question. They can give a question stating that retained stones after 2 years. No, retained means during the operation there is some retention of some stone, right? So retention of stone within 2 years of cholecystectomy occurs in 1 to 3% patients. And recurrent stones, those are the brown pigmented stones, occurs in CBD after 2 years of cholecystectomy. Remember, after 2 years of cholecystectomy. So these are the basic first introduction into the CBD stones means. Now let us understand the clinical features of these common bile duct CBD stones. Now there is an obstruction, right? There is a stone in the CBD. So the conjugated bilirubin, which is formed, right, in the gallbladder, not able to move into the second part of the duodenum. So what happens? There is increased conjugated bilirubin, right? So remember that now once there is an obstruction to the common bile duct, the person has a pain because there is an obstruction. It stimulates the pain pathway. Because of the obstruction, there is increased conjugated bilirubin, so there is a jaundice. Because of the obstruction, there is an increased content of bile salts, right? And these bile salts or the bile ducts has, because of the obstruction, there is increased bile duct pressure and causes, there is an bacteria and toxin points, right? So this bacteria which is present in the CBD because of the obstruction. Now what happens is bacteria can go into the blood and they can cause an infection and cause a fever. So a person who has an obstruction, what do you mean? When do you call this an obstruction jaundice? You call the patient as an obstructive jaundice if a patient has a pain, right? Where exactly the pain? Where exactly? Yes, I've told you at you have hypochondrial, right? Hypochondrial region, right? And this pain can be of sudden, and this is of sudden intense pain in the upper right hypochondrial right abdomen or the upper stomach caused by the gallstones therapy temporarily. Okay, so now what is it trying to tell us? There is a pain, there is a jaundice, there is a fever here. Now say example, the patient is not treated for this Charcot's triangle. Now addition to this pain, jaundice and the fever, the patient can have hypotension, the patient can have altered mental status. Why it is known as altered mental status? Because the obstructed part, there is an accumulation, there is a high bile duct pressure and causes and the bacteria and toxin to escape into the bloodstream. So what if they trigger a widespread inflammation? There can be vasodilation, there can be a septic shock. And there can be a altered mental status. Why there is altered mental status? Because there is cerebral hypoperfusion. There is a cerebral hypoperfusion, right? Cerebral hypoperfusion. You understanding, right? The next important aspect is on this pain, jaundice, fever, hypotension, right? Hypotension, and altered mental status. This 5 considers into Raynaud's pentad. Raynaud's pentad, right? So, why it is very important here? The Raynaud's pentad has a mortality of 40 to 50%. Good. And these Charcot's triad, Raynaud's pentad, right? They cause an infection or the inflammation of the CBD, and they lead to cholangitis. Right. Now, how do you treat such patients? Since there is an hypotension, you give IV fluids. Since there is a bacterial into the blood, you give higher antibiotics, and you do something known as ERCP, right? You do an ERCP, and you can also do a stunting here, right? You can do a stunting. Now, let us understand what exactly it is, right? The features of common bile duct stone. That means now you want to do cholecystectomy, right? Cholecystectomy. But I want to look into whether there are any features of common bile duct stones. Because you do a cholecystectomy, because the stones are present in the gallbladder. Now, what is the use? You do a cholecystectomy, but the stone is present still in the CBD. Now, what are the features suggestive of CBD stone? The features suggestive of CBD stones are, one is biliary type pain. What do you mean by biliary type pain? It is a sudden intense pain in the upper right abdomen or center upper stomach caused by gallstone temporary. So there is a temporary sudden intense pain in the upper right abdominal or center or upper stomach caused by gallstones, right? And because of this biliary type pain, the patient, because of the stone, there has a jaundice here. The patient can have an elevated ALP. Why there is elevated? Because of the stasis. The bile acids damage the biliary epithelial cells, so that they increase epithelium lining. So what happens? There is an increased in the ALP, alkaline phosphate. Okay. Biliary epithelial cells in the hepatic points. And we should also understand, if a CBD is dilated, how much dilated? If the CBD is dilated more than 8 mm. So these are the features suggestive of CBD stone. Now, what do I do if a patient has a jaundice? Look for the ALP, right? Look for the CBD dilatation before doing cholecystectomy. Look for any biliary type pain. If these are suggestive features of CBD stone, now what I do is, I do something known as MRCP. Why do I do some MRCP? Because what is MRCP? MRCP is a magnetic resonance cholangiopancreatography. Now, why do I do this magnetic resonance cholangiopancreatography? Because I want to look for the stones in the CBD. So the best non-invasive investigation of choice for the CBD stone is MRCP. It is MRCP, that is 90% sensitive. Remember, it is 90% sensitive. And it is of 99% specific. That's what we need to understand. When I tell it is a 90% sensitive, when I tell it is a 99% specific, then I can prefer MRCP before cholecystectomy. Now, say example, if a stone is present. If there is no stone, you can go for the cholecystectomy. I've done a magnetic resonance cholangiopancreatography. If the stone is present, now what do? I need to remove the stone. What is the use of doing cholecystectomy? So I need to remove the stone. Now how do I remove the stone? I use something known as endoscope, retrograde, cholangio, pancreatography. That is a gold standard to remove the stone. So 75% stones are cleared. The 90% stones are cleared on the second ERCP. Now when I do a endoscopic retrograde cholangio pancreatography, the 75% stones are cleared. 90% stones are cleared on the second ERCP. In some conditions, I cannot do ERCP. Why I cannot do ERCP? Because if if the stone is a large stone, I've told you the CBD itself more than 8 mm, we call there is suspecting of CBD. If there's a large stone which is more than 2.5 centimeter, it is difficult for the ERCP, right? And if you have any after anatomical alteration like Roux-en-Y anastomosis, right? Roux-en-Y anastomosis. Now I've already discussed. Now we'll be discussing it. This is how Roux-en-Y gastric bypass. This is a stomach, duodenum, jejunum. Now what I do is, you can see this jejunum we have attached to the point, a proximal point. Okay. So this is the jejunum. This is the bypass, and it is attached to the duodenum. So in these conditions also, in this condition, why you can, because endoscope is not passing up, because you have an altered anatomical structure here, right? Anatomical structure. So altered anatomy, that is Roux-en-Y anastomosis. You have an impacted stones. Impacted stones are the stones which stuck and fix, the stuck and the fix in one place. Those are impacted stone. Next is intrahepatic stone. What is intrahepatic stone? These are the stone which is seen in the liver. Those are the intrahepatic stone. Intrahepatic stone. Next you have multiple stones. Next, what do you have? We have something known as multiple stones. Multiple stones. So if you have many multiple stones, it's very difficult. Okay, very difficult to get it. And you have to have intrahepatic stone. If the stone is present inside the liver, it is very difficult for the ERCP to do that. Okay, so these are the conditions. These are the conditions where we cannot do a ERCP. It's very difficult, right? So if you say example, a patient has come with a pain, jaundice and fever, right? And remember that this Charcot is high specificity. If a patient has pain, jaundice, fever, it is specific. It is no doubt he has an obstructive jaundice, right? Charcot's triangle. If a patient, but the problem is low sensitivity, because the patient, a 90% patient have a fever, but only 50 to 70% patient have all the three symptoms, all the symptoms. So that is how we need to look into this drawback. Okay, that's all for now. Let's look into next session. Thank you.